Good evening to you all. The next talk is on bempedoic acid, which is a non-statin molecule, not known to us much about that, and it is a hypercholesteremia management drug. Particularly, it lowers the LDL cholesterol. To talk on this subject, none other than Dr. Jabir Abdullakutty is here. We need not introduce Dr. Abdullakutty. Right now, you have seen the involvement of Dr. Abdullakutty in our clinical discussion and all. But for the sake of introduction, I need to introduce Dr. Jabir. Dr. Jabir Abdullakutty is a senior consultant and interventional cardiologist in Lisie Hospital. He has got more than 20 years of clinical experience, and he is an active member of and active leader of Cardiological Society of India. He had all his ladders in Kerala state, and now he has gone into the national level in Cardiological Society of India. He is a sought after speaker in the national level and international level. Over to you, Dr. Jabir.
Thank you, Dr. Sunny. I'm overwhelmed with the introduction. It's Dr. Sunny is a close friend of mine, and many other friends are here, and it's a pleasure to meet Dr. Korud after a long time, perhaps after 8 or 10 years, though we are so close by and we work together for 3-4 years. I'm meeting him after it's almost 10 years, isn't it, Korud? Pleasure, really a pleasure. So I'll be talking not on bempedoic acid alone. It's basically in dyslipidemia, why should there be a non-statin drug? We have been talking about statin, and it is one of the most, I think it is the most boring topic you can have for a discussion. So if you look at the atherogenic lipoproteins are lipoproteins with a ApoB. And in a fasting state, 90% of the ApoB containing lipoproteins, they are in the LDL. Then we have the lipoprotein A and the remnant molecules, the VLDL and the IDL. So these complicated pictures are there, which shows the different metabolisms, the chylomicrons acted upon by the lipoprotein lipase, the triglycerides are removed, and the triglycerides are acted upon, and are converted to the fatty acids taken up by the liver. There again the VLDL is synthesized, it is secreted, acted upon by the lipoprotein lipase, it becomes remnant particles and converted into LDL, then the HDL. So it's pretty complex mechanisms, but 2 or 3 things important. The liver plays a major role in the metabolism of LDL, where the LDL receptors are important, which is in the surface of the liver, which takes up the LDL, which is in the circulation. So all the studies so far, we have numerous, what is called enormous data. These enormous data shows only one thing. LDL cholesterol is the primary target of therapy, and lowering LDL cholesterol has been found to have a great benefit in terms of reduction in the atherosclerotic cardiovascular events. So this was evident in the observational studies, epidemiological data, Mendelian randomization studies, plenty of RCT studies and animal experiments. They say one thing, they found one thing. The LDL cholesterol is the causal agent for atherosclerosis. And not only the LDL cholesterol, how much time our body environment is exposed to a high LDL cholesterol. If it is for a short time, the chance of atherosclerosis development is less. If it's for a long time, high LDL cholesterol throughout the life, that is worse than having high LDL cholesterol for a limited period of time, and this is well documented with the familial hypercholesterolemia. So patients with a familial hypercholesterolemia, if they have a lifetime elevated LDL cholesterol and therefore have exceedingly high cardiovascular risk, and from birth itself they are exposed to high cholesterol, because a neonate usually has a LDL cholesterol of around 15 to 25 milligram per deciliter. These people are exposed to more than 100 or 200 milligram per deciliter of LDL cholesterol from the beginning onwards, and they develop atherosclerotic cardiovascular disease quite young, by 20 years or 18 years or by 30 years. And the focus on the global or the total cardiovascular risk of the patient. When the LDL cholesterol is important, do not focus just on the number. Look at the comorbidities and the total risk. And this is the thing. You look at the magnitude of the LDL cholesterol reduction. If from 175 to less than 50, the hazard ratio continuously coming down. And there is a graded decrease in the event rate when you look at the LDL cholesterol from 190 to less than 50, from 34.4% to 4.4%. So the magnitude of the LDL reduction is important, and the absolute value of the LDL to which the system is exposed, that also determines the development of atherosclerosis. We have plenty of data which says that LDL is the primary target and the statins are the mainstay of therapy. Not only the statins are mainstay of therapy, we can see that what is the amount of LDL reduction produced by the statin. When we compare with more than 50% reduction to less than 50% reduction or no reduction at all, there is a significant difference in the life expectancy or the mortality. So a quarter of a century of treating LDL cholesterol. 20 years back, we thought at that time, the entry point for a cholesterol lowering trial was a total cholesterol of 250 or 300. We never thought that we should reduce it to very low. And people were afraid of reducing cholesterol because cholesterol is important for certain physiological function, sex hormone synthesis, for cell wall synthesis. So whether it is really good to reduce the cholesterol. So high is bad, then came average is not good, and finally 10 years ago it is lower is better, and even lower it is even better, and now our concept is lowest is the best. And there are situations when statins are not enough, or we cannot give statin. Basically 4 situations. A goal LDL is not attained with maximum tolerated dose of statin, or there is a true statin intolerance, or there is associated other lipoprotein increase like a hypertriglyceridemia or presence of low HDL. So the molecular targets are either DNA, mRNA, or the protein per se. So the examples are now, it's changing, the scenario is changing, the horizon is widening regarding the lipid lowering agents. Now we are considering the possibility of the gene editing for controlling the lipid, for controlling the dyslipidemia, or to keep the LDL cholesterol the lowest possible. So the CRISPR, that is a gene and the basic base editing, or the use of new molecules like an antisense oligonucleotide or a small interfering RNA, which inhibits the synthesis of the RNA, and the the transcription process itself is inhibited so that the protein synthesis can be inhibited, and it reduces the synthesis of molecules which can lead on to a change in the LDL level. Then the third group is the antibodies and the small molecules. So these are it. We have the application examples. The antibodies, monoclonal antibody PCSK9, we have the small molecules like the small interfering RNA molecules like inclisiran, and then the real small molecules that we use, HMG coenzyme reductase, that is a statin, NPC1L1, that is a transporter where ezetimibe acts, and the ATP citrate lyase where bempedoic acid acts. So this is the evolution of lipid lowering therapy. We started from the statins. Before the statin, we have the gemfibrozil and all. Then the statins with plenty of data in secondary prevention and primary prevention, and they become the mainstay of therapy. Then other drugs, ezetimibe, icosapent ethyl, icosapent ethyl, bempedoic acid, fibrate, which should be given daily. Then the monoclonal antibodies, which can be given either monthly or bi-monthly, the alirocumab, evolocumab, and evinocumab. And the new one coming in, that is the antisense oligonucleotide, volanesorsen, vupanorsen, and pelacarsen. Then the small interfering RNA, which can be given once in 6 months, inclisiran and olpasiran, and going for gene editing so that it is a lifelong therapy. And now question, LDL is the main target, non-HDL cholesterol, because non-HDL cholesterol capture all the atherogenic apoprotein B containing molecules. And this is correlated well with the ApoB. So ApoB containing molecules are all captured in the non-HDL cholesterol, the total cholesterol minus the HDL cholesterol. And it is well correlated with the ApoB. So now the new molecules which is used for monitoring the therapy is either ApoB or non-HDL cholesterol, which can tell us whether we are dealing or we are managing the entire gamut of ApoB containing lipoproteins. And the new target is the lipoprotein A. So these are the major large number of drugs which is coming in, the antisense oligonucleotides, the small interfering RNA and the monoclonal antibodies. And future will be of these drugs. If you can take a drug injection once in 6 months or once in a year, and it will control your lipid status, then that is will be, if the cost is bearable, then that's going to change the game forever. So bempedoic acid, the pelacarsen and the olpasiran, these reduces the apoprotein A, and they are good in reducing the lipoprotein A. The evolocumab and alirocumab are the monoclonal antibodies which inhibits the PCSK9, and we have the newer molecules, which is the angiopoietin-like protein or angiopoietin-like peptide ANGPLT3 inhibitors, that is volanesorsen and evinocumab, and volanesorsen, that is the ApoC3 inhibitor. So these are the new things that is coming in, and this molecule is important, the lipoprotein lipase. The lipoprotein lipase basically acts on the triglyceride-rich lipoproteins, and the triglycerides are broken into fatty acids. So these are inhibitors of lipoprotein lipase, apolipoprotein C3, ANGPTL3, ANGPTL4, apolipoprotein A5. So they really inhibits the lipoprotein lipase. When they inhibits the lipoprotein lipase, actually the triglyceride level increases. And if you use an inhibitor of these molecules, inhibitor of apolipoprotein C3, inhibitor of ANGPTL3, or inhibitor of this angiopoietin-like peptide 4, then the lipoprotein lipase level increases, and the triglyceride-rich lipoproteins comes down. The triglyceride-rich lipoproteins have also been found to have atherosclerotic potential. So these are the new drugs coming in. It is inhibitor of an inhibitor. So intensification of the lipid lowering therapy, and what is the magnitude of the LDL reduction you can get. A moderate intensity statin, is a 5 to 10 milligram of a rosuvastatin, or 10 to 20 milligram of a atorvastatin. A high intensity statin, it's 40 to 80 milligram of atorvastatin, or a 20 to 40 milligram of rosuvastatin, which produce 50% reduction, and that is the target we aim for. A high intensity statin plus ezetimibe produces 65% reduction, and a PCSK9 inhibitor alone produces 60% reduction in the LDL cholesterol. A PCSK9 inhibitor plus high intensity statin produces 75% reduction in LDL cholesterol. If we give the three things together, PCSK9 inhibitor, high intensity statin plus ezetimibe, it produces 85% reduction in the LDL cholesterol. And the new molecule bempedoic acid, which produce by and large alone, it produces 18% reduction in the LDL cholesterol. So its capacity to produce a LDL cholesterol reduction is not as great as a high intensity statin, maybe perhaps 1/3 of that of a high intensity statin. Plus ezetimibe, it can produce a 38% reduction. And the new concept that is evolving, especially in those patients who cannot tolerate a dose of a high intensity statin, that is bempedoic acid plus ezetimibe plus a small dose of statin, which may not produce much of the side effects, like especially the statin associated muscle symptoms. It can produce a 60% reduction, that is equivalent to that of a PCSK9 inhibitor. So bempedoic acid by itself is not a very potent agent, but when combined with ezetimibe plus atorvastatin, it can become a potent agent. Only problem is we don't have an outcome data. I'll show you one or two cases. A 45-year-old male, family history of dyslipidemia and coronary artery disease. Her two brothers died at young age due to myocardial infarction, and one sister had undergone coronary artery bypass grafting at the age of 40. She had a positive TMT, and an angiogram was done following a positive TMT, which revealed LAD disease, and she had undergone a PCI 4 years ago. She is on 40 milligram of rosuvastatin and 10 milligram of ezetimibe. You can see this tendon xanthomas, which is the hallmark of the familial hypercholesterolemia. This seems to be a homozygous familial hypercholesterolemia. And the use of 40 milligram of rosuvastatin plus ezetimibe 10 milligram, her cholesterol level is 442 serum cholesterol, and LDL cholesterol is 369, HDL cholesterol is 55. So it's extremely difficult to control. Now we don't have much potent agents available, so this patient requires a non-statin therapy on the top of this, and that must be the commonly available thing right now is a PCSK9 inhibitor. So PCSK9 inhibitor is something which may be a revolution in the therapy of lipid abnormalities. So the way the LDL comes and binds to the LDL receptors on the liver surface. And when there is the PCSK9 is present, the PCSK9 plus the LDL receptor and the LDL will be taken to the lysosomes. So they will go to the lysosomes. Normally when the LDL receptor plus LDL go to the lysosome for degradation, the LDL is degraded and the receptor comes back to the surface. But when there is a PCSK9 available, the PCSK9 plus LDL receptor plus the LDL goes to the lysosome for degradation, and the receptor, LDL receptor, will not recycle back. That also will be destroyed or degraded. So there will be a decrease in the availability of LDL receptor. So when the LDL receptor level comes down because of the presence of PCSK9, the LDL level rises. So this was found first in a group of population who had a deficiency of PCSK9 or PCSK9 loss of function allele. They found that they are resistant to development of atherosclerosis because of the low LDL cholesterol. So actually PCSK9 is a chaperone with the LDL and the receptor, which prevents the recycling of the LDL receptors and reduces the level of LDL receptors on the hepatic surface. So when you give a PCSK9 inhibitor, what it does is it reduces the PCSK9, so the recycling of the LDL receptors will be more active, and the presence of more receptors on the liver surface helps to reduce the LDL cholesterol level. So that recycling will be continued or will be augmented in the absence of PCSK9, and this is the mechanism behind the use of PCSK9. We have data from two studies, the Fourier and the Odyssey outcomes. Both have shown there is a reduction in the outcome in terms of a combined endpoint of cardiovascular death, MI, stroke, hospitalization for unstable angina or coronary revascularization. Fourier, it was all type of atherosclerotic cardiovascular disease. Odyssey, it's following a ACS, 1 month after ACS. And the Fourier trial, the summary, they have shown that there is a 59% decline in the LDL level on the top of maximally tolerated dose of statin therapy in 27,564 patients, a 60% additional LDL reduction. And you can see the reduction in the endpoints. And this reduction in the endpoints were more prominent in those patients who are at high risk, like those who had a recent myocardial infarction, those who had diabetes, those who had peripheral arterial disease, those who had a cerebrovascular disease. And the most important thing, everybody is afraid of, all patients will come to us and ask, sir, my LDL cholesterol is only 40, my total cholesterol is 100. And the lab people tell, go immediately run to your doctor and ask him, your LDL cholesterol is, I'll always tell, look, you should be worried only about a high LDL cholesterol. If your LDL cholesterol is 200, you should run and meet a doctor. If your LDL cholesterol is 60 or 50, be happy and remain at home and free from atherosclerosis. And this particular study has shown that 10% of the patient, more than 500 patients in the study, had an LDL cholesterol of less than 20 milligram per deciliter, which is equivalent to that of a neonatal level of LDL cholesterol, and there was no particular adverse effect. There was no particular adverse effect which we had a concern about, like a cerebral bleed or a memory impairment, development of cataract. There were no safety concerns with very low LDL cholesterol of even 7 milligram per deciliter. So PCSK9 inhibitors, they reduce LDL cholesterol to the tune of almost 60%, reduces apolipoprotein B, reduces lipoprotein A, reduces triglyceride to a small level, increase HDL cholesterol to a small level, and increase the apolipoprotein A1 4 to 5%. A 45-year-old, so this patient, we have to use PCSK9 inhibitor. Only thing is the pocket toxicity. It costs around 20,000 rupees per injection, so 40,000 rupees per month, which is beyond the pocket of large majority of the Indian population. 45 years old male, anterior STEMI 5 months ago, he had a post-primary angioplasty. He had an angioplasty done at that time. Now post-primary angioplasty on dual antiplatelet therapy, 40 milligram of rosuvastatin and bisoprolol. He complains of fatigue and muscle pain. I don't know whether you can read. We investigated and found that he has a creatinine. His creatinine was normal. It was 1.5 at the time of discharge. And at the second month of follow-up, his creatinine is 6.79. The potassium is 6.3, close to 6.3, and the CPK is 21,671. It is much above the 10 times the upper limit of normal, and the patient was diagnosed to have a rhabdomyolysis. He remained with us for 2 weeks, multiple sittings of dialysis, finally improved. His creatinine normalized. It took around 3 months for his creatinine to come down to normal, and I won't dare to re-challenge him with a statin again. So what is the option for this person? His last LDL cholesterol, when we looked at, is 153, which is much above the target which is required. So the new option is bempedoic acid. Bempedoic acid also acts in the same pathway where the statin acts. Before the HMG coenzyme reductase, it acts at the, it inhibits the enzyme, the ACL, but the only problem is this has to be converted. This is not like statin. This is a prodrug which has to be converted by the long chain acyl coenzyme particular enzyme, which is present only in the liver. Fortunately, this is not there in the muscle, so this drug cannot be converted to its active drug in the muscle, so mostly devoid of the muscle problem. So it is the acyl coenzyme synthase, which is a long chain enzyme which is not there in the muscle. So this is a drug which may be suitable for patients with statin intolerance or statin associated muscle symptom. And the enzyme it targets is the ATP citrate lyase. This also upregulates the LDL receptors and lower LDL cholesterol. So that specific enzyme is not available in the skeletal muscle, so muscle problems are likely to be less. So those patients who had a rhabdomyolysis or severe muscle symptoms or myositis with the statin can be safely changed over to this drug, but the magnitude of the LDL reduction is less when compared to the statin. We have plenty of data with these studies: Clear Harmony, Clear Wisdom, Clear Serenity, all clear trials. They looked at either patients on maximally tolerated statin therapy who has not reached the target LDL of less than 70, or atherosclerotic cardiovascular disease plus heterozygous familial hypercholesterolemia on the top of maximally tolerated statin therapy, or true statin intolerance where low dose statin plus this drug, or statin intolerance where ezetimibe plus low dose statin. That is the background therapy versus bempedoic acid. And the clear tranquility, they found that around 23.5% decrease in the LDL cholesterol. And the phase 3 studies for LDL lowering, the tranquility, harmony, serenity and wisdom, 15% to 23%. So the maximum reduction with bempedoic acid alone is almost 23.6%. With ezetimibe, it can go up to 38%, and with a low dose statin plus, so 3 drugs together, it may go up to 60% reduction. We don't have an outcome study data with bempedoic acid right now, but an outcome study is going on, that is the clear outcome data. So this of large number of patients, 14,000 plus patients who had a history of statin intolerance with a fasting blood LDL cholesterol of more than 100, randomized to placebo versus bempedoic acid 180 milligram, and bempedoic acid is a single dose tablet of 180 milligram. Any adverse effects? Are we paying any cost? Some unusual things. One is elevation of the blood uric acid level. The uric acid level can increase, creatinine can increase to a little bit. It may precipitate a gout in those patients with a baseline high level of uric acid. This is basically due to its effect on the transporter of uric acid. The transporter of uric acid, which helps in moving the uric acid out of the kidney into the tubule and then through the urine. So it has got an anti-uricose uric effect. So those patients who had gout or who have elevated uric acid levels and who are at risk of gout should not be treated with bempedoic acid. And there was some incidences of tendon rupture also found with bempedoic acid. Otherwise, no much adverse effect. So this, the patient whom I mentioned, the rhabdomyolysis, renal failure, 2 weeks dialysis, now normal RFT, no statins, and we have introduced bempedoic acid to this person. Statin associated muscle symptoms. Myalgias are infrequent in RCTs, but very frequent in the observational studies. So that is why people think of this is a nocebo effect. It may not be a true myalgia. Myositis or myopathy, where the CK is more than upper limit of normal, it is rare. Rhabdomyolysis we consider when the CK is more than 10 times the upper limit of normal. And another one is the statin associated autoimmune myopathy. New onset diabetes is another problem, but usually it's uncovering of diabetes in a person who is destined to develop diabetes, especially in patients with a metabolic syndrome, strong family history of diabetes, and a baseline HbA1c of more than 6%. And transaminase elevation, it is basically a transaminitis, may not produce fatal liver injury, and fatal liver injury is extremely unlikely with statin. So case 3 is a 34-year-old male, no cardiac symptoms, he is diabetic, there is a family history of CAD, and a lipid profile was done as a part of medical checkup, and the lab people told him that, look, your blood looks like milk, your serum looks like milk, and his cholesterol FBS was 174, ppbs 236, unlikely for this diabetes to produce this much triglyceridemia, though diabetes can increase the level of triglyceride. And his triglyceride when I saw him first was 2895. And we repeated it in May 2019. First I saw him in April 2019, then May 2019, it was 2310. So non-statin evidence in patients with elevated triglyceride. The best evidence right now we have it from the REDUCE-IT trial, which is the drug used was icosapent-ethyl, which is a synthetic pure form of omega-3 fatty acid icosapent-ethyl, not a mixture what we get now in our market, icosapent-ethyl plus the docosahexaene acid. It's a pure icosapent-ethyl, and they found that there is a benefit in terms of reduction in the endpoints. And this is a class 2B indication in some of the guidelines. So hypertriglyceridemia, first drug of choice for reducing cardiovascular disease risk in high risk individuals with a triglyceride of more than 200, class 1 indication is statin. And in high risk with a triglyceride between 135 and 499, despite a statin treatment, there is a class 2 indication for the use of icosapent-ethyl. This is specifically icosapent-ethyl because the next trial, the next study, where they used a mixture of icosapent-ethyl and the docosa salt, they could not replicate the benefit. That is the strength trial. In the primary prevention patients who are at LDL cholesterol goal and with a triglyceride more than 200, you can use a fibrate, a fenofibrate or a bezafibrate. And in high risk patients who are at LDL goal with a triglyceride more than 200, fenofibrate or bezafibrate. So basically, very important thing is the diet restriction. It's not the fat restriction alone, a carbohydrate restriction, especially a simple carbohydrate and sugars, that is extremely important to control the triglyceride. Exercise, so lifestyle modification, major role, followed by the drug you can use is omega-3 fatty acid, at least 4 gram. We don't have icosapent-ethyl with us right now, we have only the mixed salt, so it is 4 grams at least, that is also costly. Then fibric acid, then the saraglitazar. So we started this patient on first on fibric acid, there was no improvement. We added saraglitazar, nothing. Then we added, there was some amount of reduction, and finally we gave a combination of fenofibric acid, saraglitazar and omega-3 fatty acid, and his triglyceride came down to 208. But when he came for a follow-up in 2020, that usually happens, our patients stop all the drugs. He stopped all the drugs together, and when he came back, his triglyceride was 5,361. No, that's they all, because they are not symptomatic. That is the difficulty of treating a symptomatic disease. When you treat a symptomatic disease, patient feels that this doctor is unnecessarily giving costly medications, because altogether these 3 drugs together is a huge cost, and he doesn't have any symptoms. So naturally, and he might have been got advice from some other people also. He stopped all drugs. It jumped up, and hypertriglyceridemia is very difficult to treat. Regarding the HDL and raising the HDL, extremely disappointing results with niacin, because though it reduced the HDL, though it improved the HDL and reduced the LDL, there was no benefit in the 2 studies, the AIM High study and the HPS Thrive. Both the studies could not find any benefit. CETP inhibitors, the traps, the Torsi trap, lot of drugs came in. Very disappointing result. So finally our conclusion is, this is a very complex molecule whose real role, mechanism of action and how it acts, we do not really know. So there is a limited understanding regarding the HDL. So far regarding HDL raising, the pharmacological attempts are quite frustrating. We don't have any data. So the case 4, the last one I am showing is, this is a patient who had multiple events initial stenting followed by re-stenting followed by re-ACS. So he had multiple times he had or recurrent atherosclerotic cardiovascular events. That is the highest risk of patients with atherosclerotic cardiovascular disease. His cholesterol level we tried to control with 40 milligram of rosuvastatin and 10 milligram of ezetimibe. And this is the last LDL. On this drug, his LDL cholesterol level is 184 and triglyceride is 187 with a low HDL of 34. So this patient also is a candidate for PCSK9 inhibitor. Actually, we discussed with the patient, we have taken up this patient for a clinical trial where we are using inclisiran. Inclisiran is used once in 6 months. Inclisiran is now licensed for use in Europe. So we have enrolled him into a study where we can use the inclisiran. So the drug therapy for dyslipidemia 2019 ESC guidelines, high intensity statin for the highest risk patient. Has the LDL cholesterol goal reached by 4 to 6 weeks? No. Add ezetimibe. Again re-evaluated 4 to 6 weeks. Has the LDL cholesterol goal reached? Yes. Then annually or biannual follow-up. If not, then a high-risk situations where it is a secondary prevention, very high-risk group of patients, or a primary prevention in patients with familial hypercholesterolemia and another major risk factor, or a primary prevention at patients at very high risk but without familial hypercholesterolemia. Think of PCSK9 inhibitor. I might have given some PCSK9 inhibitor for 15 patients or so, and part of a study where we used it. Otherwise, it is very difficult to use this drug unless we get insurance support. So the most important thing, having said all these things, the use of high intensity statin, the use of newer molecules, the widening horizon of the new molecules, a lot of fancy molecules coming in which can control the triglyceride, the newer molecules like ANGP, PLT3 inhibitors, so they can reduce the triglyceride by around 80%. But in the real world, what happens in Europe, this study which is known as the Da Vinci study published 1 year ago, they found that the real control of lipid with the use of statin is less than 50%. With the 2019 goals, only around 30% achieve the LDL goals. So, though these new molecules are there, we should know about the new molecules, its use, indications. The most important thrust should be given for treating all patients with high risk atherosclerotic cardiovascular disease or who are at high risk of developing atherosclerotic cardiovascular disease with statin quite early and try to reach the LDL cholesterol goal level. So my final thoughts are application of the knowledge is the key to success in the patient management. There is no point in knowing alone, but we should apply it. And statins remains the cornerstone therapy in reducing atherosclerotic cardiovascular disease. Non-statin drugs are needed in specific situations. The horizon of lipid lowering therapy is widening with more and more therapeutic targets as well as more and more gadgets. Thank you so much.
Thank you, Dr. Jabir, for the wonderful and excellent talk. As usual, it was a crystal clear, crisp, and again a wonderful talk. Yeah, he has mentioned about the management of dyslipidemia rather than introducing the new molecule bempedoic acid and the newer guidelines, and he shared his vast and rich experience in the management of coronary artery disease and lipid management. So the forum is open for questions and answers and comments also. Dr. Jabir, you can sit here.
Right. There are a few differences. For example, atorvastatin is a lipid-soluble statin and the rosuvastatin is a water-soluble statin. The potency is little different. 80 milligram of atorvastatin produces around 50% reduction, maximum reduction in the LDL level, and 40 milligram of rosuvastatin may produce around 57 or 56% reduction in the LDL level. The triglyceride lowering capacity of rosuvastatin is a little bit better than atorvastatin. So if the triglyceride also is high, I may opt for a rosuvastatin rather than a atorvastatin. And the third thing is the HDL increasing capacity of rosuvastatin also little high. But then the rosuvastatin, there is some data which shows that it may produce problems, especially a proteinuria or even hematuria in Asian origin people. But later on this, that was a doubt when drug was initially introduced, but later on disproved. But even then, all the guidelines says in Asian population, you be a little careful with the use of rosuvastatin. And the hepatic toxicity and all is maybe a little bit lower with rosuvastatin because it is a water soluble rather than a lipid soluble one. I don't have any experience with pitavastatin. Though this drug was introduced, this is basically a Japanese molecule. Drug was introduced long way back, almost 10 years since its introduction into the market. The use is less. But many people consider that if a patient is intolerant to statin, you may try another statin at a lower dose, and if the symptoms are not controlled, even alternate day dose. One option is pitavastatin.
Regarding bempedoic acid, do we have any studies to prove that there is a clinical benefit? I am
No.
not speaking about LDL low.
No outcome studies.
No, that's
one outcome study that is going on is the clear study, the clear outcome study.
No, because-
That the data
no,
is not at all.
Because there's an important lesson from history. When ezetimibe was when it first came into the market, everyone told that it's good in reducing LDL cholesterol. But when they did studies on the atherosclerotic plaque, it actually didn't reduce much difference in the size of the plaque. So for some time, ezetimibe took a back seat, and later has come back, but in combination with statin. So on a similar parallel, I'm just asking whether do we have such studies to prove, or are we actually barking up the wrong tree, or because, or is it a pharmacological, companies, pressure from pharma side that they are trying to promote bempedoic acid, when as of now we don't have any data to prove that there is a clinical benefit. It might reduce the LDL benefit, but in actual clinical practice, does it actually produce a benefit?
I fully agree with you. Look, ezetimibe was introduced some 12 years ago. At that time, we had a concept that a 10 milligram of ezetimibe plus 10 milligram of atorvastatin is equal to 40 milligram of atorvastatin. We all started initially. Then there was no outcome trials, as you mentioned. We do not know whether it is really clinical benefit is produced, or the clinical benefit is really due to a high dose of statin and its pleomorphic advantages. So gradually the ezetimibe moved away. We don't have any even good brands of ezetimibe in the market. Only 1 or 2 drug companies are having ezetimibe in the market. Later, when the improve it trial came, it produced a marginal benefit, almost 8% additional benefit with the use of simvastatin 40 milligram with this ezetimibe. That is the only outcome data available. Then it became a class 2B indication. Now regarding the bempedoic acid, hope there are no industry people inside. It's not a magic molecule. When we compare the tremendous amount of data with the statin and the long track record of the statin, this is a new kid in the block, which showed that there is a reduction in the LDL cholesterol to the tune of 20%. Then whether it really produces a clinical benefit, we extrapolate that reduction in the LDL reduces the atherosclerosis, it inhibits the progression of atherosclerosis, it produces some regression of atherosclerosis. These all occurs at a higher intensity of the reduction, high magnitude of reduction in the LDL cholesterol. Is this LDL cholesterol reduction sufficient to prevent the atherosclerotic event rate? We do not know. But then, certain patients, we don't have any options. When there is a no option situation, statin he cannot tolerate at all. For example, rhabdomyolysis, I'm afraid I will not touch that patient again with statin. But liver okay. But rhabdomyolysis, especially who had undergone dialysis, no. So that situation, to reduce the LDL cholesterol, this is an option. This plus ezetimibe will produce a 38% reduction. Plus if we can give a small dose of statin, that is a good combination. But in that case also, we lack evidence. We lack evidence of clinical benefit.
Is there any other molecule, a lot of molecule have said, that can stabilize this plaque apart from the statin?
Yes, PCSK9 inhibitor. PCSK9 inhibitor, there is actually a trial called the GLAGOV trial. In the GLAGOV, what they looked at is they gave PCSK9 inhibitor and they looked at the reduction in the LDL cholesterol, and they did a intravascular ultrasound study. And with the intravascular ultrasound, they looked at the regression of the plaque. So they could find a regression of the plaque, significant regression in the plaque burden by giving PCSK9 inhibitor. So it all basically tells us one thing. You reduce the LDL cholesterol intensively, go to the lowest level, the plaque may get passivated. It all depends upon the plaque activity, depends upon the free lipid in the plaque. So if the lipid core is more than 40%, it's likely to be a vulnerable plaque. So reduce the lipid level. That is the easiest thing that we can do. Which one? Yes. For except for extreme liver dysfunction or renal dysfunction, this can be given. Only thing is we have to look at the uric acid. We should have a baseline uric acid level and a follow-up uric acid level. Uric acid level can go. If the patient is on, I'm afraid of one thing, we are giving ticagrelor, that also can increase uric acid level. So if the patient's baseline uric acid is 7.5, we give ticagrelor, what I have seen is it increases by around 1 or 1.5, it becomes 8.5. And we give bempedoic acid, it can become 9 or 10 and he can have precipitation of a gout. That's the one thing we should be careful about.
Is there any questions more? If there are no more questions, we will wind up the session. And I think Dr. Jabir deserves a high applause.
Thank you, sir.
Thank you, Dr. Jabir.
I request Dr. Orathel to come forward and give a moment to Dr. Jabir. I request Dr. Raju sir to come forward and give a moment to Dr. Sunny sir.